Well, good afternoon, everybody. My role is to talk about the MINAP, the Myocardial Ischemia National Audit Project, of which I'm clinical lead. Just to give you some background, I've called the MINAP audit a mature national audit because it's been going on for about 20 years now. The primary purpose is to collect information on the hospital management of patients with type 1 myocardial infarction. Those are events that have occurred because of coronary artery disease, atheroma predominantly. But necessarily, we will collect some information on so-called type 2 myocardial infarction, those patients in whom eventually it is thought that myocardial injury has been caused by non-coronary events. We tend to look at patients both as a whole, a group of people with acute coronary syndrome, and those separated by the presence or absence of ST elevation at the time of the myocardial infarction, namely the STEMI and the non or the N-STEMI patient. We use the audit both as a quality assurance, but mainly as a quality improvement tool. And of course, a lot of research has already come from this. We tend to express quality not in structural terms and very limited outcome terms, but we tend to look at processes, and we compare practice at a national and at a hospital level against particular standards derived from professional body guidelines and national guidelines. And we present trends over years, we present hospital performance, both in figures and in tables. So moving on to the present report, this is a slide showing the numbers of patients being submitted per year from 2010 onwards. And you'll be able to see that the N-STEMI patients, the number of patients being submitted with N-STEMI as the final diagnosis, has actually increased over the last 2 or 3 years, whilst the number of patients with STEMI has reduced. You can see here the different age bands, and you can see that STEMI patients, patients presenting with ST elevation, are made up primarily of patients up to the age of, say, 75, whereas quite a large proportion of N-STEMI patients are older than 75. If any of you are concerned about the low numbers in 2015, excuse me, 2015-16, this particular year in this particular graph is only for 9 months. This is a little bit of interesting information about the characteristics of these patients. And this is looking at those with a prior diagnosis of diabetes and those whose BMIs are greater than 30. A health warning on these slides, you'll see that the y-axis doesn't go down to 0, and this therefore accentuates the change over time. But you'll see a rise in the proportion of overweight patients and a rise in the proportion of patients with a prior diagnosis of diabetes. This, I should say, is restricted to the group of people in whom this heart attack is their first manifestation of a coronary event. These are the call to balloon times in the STEMI group. And remember that rapid treatment, from calling for help to having a primary percutaneous intervention, is the treatment of choice. And we can see that over the years, the median call to balloon time has actually lengthened. It's gone in the wrong direction for quality. And you can see a nadir, a lowest call to balloon time of 107 minutes. And we have crept up in 2017-18, it was a 2-hour, 120-minute delay, and we're up to 126 minutes. This is going in the wrong direction. And remember, this is largely pre-COVID lockdown. This is the distribution of primary PCI centres, demonstrating the performance of each of those hospitals as one of the bars with respect to the percentage of patients who receive their primary PCI within 120 minutes. And you can see this variation in hospital performance. If you look at the red bars in graph B, this is the proportion of patients in the whole of the audit who year on year, following STEMI, get a PCI within 2 hours. And you can see, unfortunately, the proportion of patients getting such timely call to balloon service is reducing. And when we look, and you don't need to look at this in great detail, graph A, or figure A, is the door to balloon time, the hospital performance once a patient has arrived. And essentially the median door to balloon time has been static, while the time taken from call to arrival in hospital has gradually increased. And that is the main driver of the prolonged overall call to balloon time. That being said, over the period over the last 10 years, we can see that the proportion of patients who do not get any reperfusion treatment at all is falling. So more people are getting reperfusion therapy. You may note at the bottom here that in this last year, fewer than 100 patients actually received thrombolytic treatment for ST elevation. Another process measure we look at is the use of an echocardiogram as the primary way of assessing left ventricular function in patients with acute coronary syndrome. And we can see on the left-hand side of your screen in A that over the years, increasing proportions of patients are indeed receiving an echocardiogram following ST elevation myocardial infarction. The graph on the right, or the histograms on the right, are individual hospitals ranked but not named. You can find the names in the tabulated report, based on the proportion of patients who have either STEMI or end-STEMI who receive an echocardiogram during the admission. And this demonstrates the wide variability, with large proportion of the hospitals performing really very well and some hospitals performing less well on this particular metric. Moving to the end-STEMI patients, and in particular the metric that has bothered us the most, and that is the timeliness of angiography in patients presenting without ST elevation. And you can see that the blue bars here, the blue line, is the proportion of eligible patients eligible for an angiogram who actually receive an angiogram during their admission with end-STEMI. And that seems to have reached a plateau of just over 80 to 85% of people getting an angiogram during the admission. But unfortunately, the proportion of patients who receive that angiogram within the NICE quality standard of 72 hours has remained pretty well the same at around about 55%. Looking at that by hospital, we see this substantial steep slope in hospital performance. The proportion of patients attending these hospitals who have got their angiogram done within 72 hours. So one or two hospitals achieving that in 90% of their patients, whereas quite a number of hospitals, fewer than 60% of their patients below to the right of the red line. So wide variation. And we in the report suggest why that might be. One or two of the other processes, and I'll wrap up then. This is the proportion of patients on the left, that's A, who having had a STEMI, having been shown to have left ventricular impairment on echo, are then prescribed appropriate treatment with an aldosterone antagonist. And we can see this slowly rising possible plateau here. This, on the other hand, excludes the aldosterone antagonist and simply looks at all comers, STEMI and end-STEMI, who are discharged on all the secondary prevention medication for which they are eligible. And that runs at around about 90% of patients. And that's a sign of good practice. This is the rehabilitation. This is referral to cardiac rehabilitation. The blue line is for those who are discharged directly home from your hospital or from the hospital that participates in the audit. The red line includes those who are both discharged or referred on to a second hospital for further treatment. And you can see that there was a worrying fall in the proportion of both groups being referred for cardiac rehabilitation, which seems to have reversed, and that reverse continues to improve back towards the aspiration that at least 85% of patients would be so referred. So those are what I would look on as the highlights: worsening call to balloon times, inability to improve the overall delay from admission to angiography, but demonstrating through variability in hospital performance that some hospitals do appear to be able to maintain that sort of performance, and we can all learn from them. I'd like to thank members of the domain expert group, and in particular the NICOR analysts and the project managers, for helping with the report. Thank you.